And welcome to the Dr. Bob Show. Have you ever had a little fluttering in your heart? It seems like it may be skipping, or the fluttering goes in runs, or it lasts a long time or a short period of time. That's the time anywhere in there that you need to be sure that you have an evaluation. If that fluttering becomes chronic, it could lead to the most common rhythm disturbance in cardiology. And we'll be spending most of this show talking about that, atrial fibrillation, because it can lead to other medical problems that can be life-threatening. My guest is Dr. George Krisle. Dr. Krisle is a board-certified cardiologist, and he'll be answering our questions. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes in the Dr. Bob Show. Later on, we'll be talking about a headache that's more common than we think, and it could be leakage of fluid from the central nervous system and gangrenous toes. What's the cause? A lot of information for you. You'll want to stay tuned. We're talking with Dr. George Krisle, board-certified cardiologist, and we're talking about a common rhythm disturbance. George, welcome to the Dr. Bob Show.
Glad to be with you.
What is atrial fibrillation?
Atrial fibrillation is an irregular heartbeat, so it goes fast, fast, slow, slow, fast, fast. Irregular.
Can the patient tell they got it?
Lots of times, especially if the heart rate gets over 110, 120, it feels like it's racing, thumping, skipping.
When it gets that fast, does the patient have symptoms?
The palpitation symptom is compelling. A lot of times it's associated with shortness of breath. And if you have underlying blockage in your coronary circulation, it can bring out some angina.
So what's the normal rate of a normal heartbeat?
At rest, somewhere between 50 and 60. If you're a great conditioned athlete like you were in your time, heart rate may have been 45. And when you're active, it's normal for it to go up to 100, 110, 120. If you're really active, it can go up to 160, 180. But that's the physiologic tachycardia response of normal exercise.
So with normal exercise, we get short of breath and our heart rate goes up. Here, the heart rate goes up. Does that make us short of breath?
It can, because if it's irregular, it's not as efficient as the regular heartbeat. So people will experience shortness of breath.
So how common is atrial fibrillation?
Very. If you reach a certain number of birthdays, like 75 or plus, about 8 or 9%, 1 out of 12 Americans, will have atrial fibrillation either intermittently, paroxysmally, or persistently.
That's very, very common. Is there a way to prevent it?
Yes, atrial fibrillation is associated with 3 O's, older, and of course you want to get older, we want that. Obesity, correctable.
Don't want that.
Obstructive sleep apnea, treatable. It's also associated with hypertension, cardiomyopathy, valvular disease. If the mitral valve leaks, it makes the left atrium get too big, and that makes atrial fibrillation come into the forefront. And there's the well-known holiday heart syndrome. Thanksgiving, we all get together, not enough sleep, too much commotion, too much alcohol, and atrial fibrillation presents as the holiday heart syndrome.
And I really didn't know that was a holiday type of rhythm disturbance. So why is it so important that we recognize and begin treatment on that?
You want to begin treatment if you're symptomatic, especially. Interestingly enough, a lot of Americans are not symptomatic, and this is detected at the annual physical exam with their doctor.
So that's not dangerous?
Well, you'd like to know about it, and so the internist or family physician picks it up and will treat it. You want to try to slow the heart rate for rate control. A lot of times you want to try to convert back to sinus rhythm for rhythm control, and you want to be on, in most instances, if you have a certain set of criteria, you need to be on a blood thinner to cut down on the stroke risk. The real issue with atrial fibrillation is it associates with stroke, and if you're on a blood thinner, there's a 65% reduction in the stroke risk.
So you mentioned with mitral valve disease that the left atrium sometimes got enlarged. That might lead to atrial fibrillation. Is the atrium where fibrillation occurs?
That's where the action is. You know, there's a right atrium and left atrium, right ventricle, left ventricle. And the atrium are the two upper chambers. And the right atrium is the source of the electrical pathway. But it's the left atrium usually where the excitable cells get going and cause atrial fibrillation.
How fast does that atrium beat?
If it can go over 200.
Wow. Will 200 beats go through?
Well, the atrial fibrillation can go like that, and how much goes through depends on the node conduction to the ventricle. But if it's 1-to-1, it'll be over 200.
So if my rate was 200, how would I feel?
You wouldn't feel very good. You'd feel short of breath, you'd feel palpitations. Yeah. It's not a comfortable feeling, and some people tell you they just flat out feel terrible.
If somebody comes to you and said, my heart was fluttering and I felt absolutely terrible, would that come to mind, atrial fibrillation?
Absolutely right, yes sir.
So if you do electrocardiogram, are they necessarily in atrial fibrillation?
Not always. Here's the way you work this up. You get a 12-lead electrocardiogram. If you find it on the EKG, you've got a diagnosis. If it's not on the EKG, you can do a 48-hour Holter to monitor the heartbeat over 48 hours. If the episodes are less frequent, you can do an event monitor, which you get to take home for 30 days and 30 nights. And anytime you have an event, you press the button and it's recorded, and then Telerhythmics sends it to us and we can diagnose it that way.
In your experience, do most people know when they're having an event, or most people don't know when they're having an event?
50% of folks will be asymptomatic. This is detected.
That's scary.
Yes, you kind of think people would be more symptomatic, but we get a lot of referrals. Someone will go to see their internal medicine consultant or family physician consultant, EKG for the annual physical, you're in atrial fibrillation, we need to address this. But 50% of people are symptomatic and either come in right away or go to the emergency room or come to us directly, and we can diagnose it that way.
So if they have asymptomatic electrocardiogram showing atrial fibrillation, why do you have to do something about it?
Don't necessarily have to. Here's the two philosophies. One is rate control. Young person, 70-ish, is asymptomatic, can stay in atrial fibrillation, keep the rate between 60 and 100. Blood thinner, Coumadin or Eliquis to help.
So you have to use a blood thinner?
You do. You want to cut down the stroke risk. That's very important. But if they're rate control, absolutely asymptomatic, great quality of life, on a blood thinner, they can choose that. And that's a lot easier for people. You don't have to go back and forth. You don't have to take a lot of different medicines that have side effects. So rate control is fine if you're completely asymptomatic. It's usually very comfortable for people 70 and up to choose that approach.
So if somebody has rate control and atrial fibrillation, is the rate low because there's something wrong with the heart? Or do most people have to be on a beta blocker?
It may mean that the conduction is sort of slowed down a little bit, so the rate is slower than you would expect. Most people, though, when it goes above 100, 110, you need a beta blocker or a calcium channel blocker like diltiazem. Both the beta blocker and the calcium blocker will slow the heart rate, and that helps you achieve rate control.
Either one is preferable, calcium channel blocker versus a beta blocker?
Both fine.
Both of them are fine, do a good job. So that's for rate control with those. You have to be on a blood thinner. Why do you pick one over the other?
Coumadin has been around 60 years. It's affordable, and the only issue there is you have to get a little blood test every 2 to 4 weeks. At the start, every 2, then once it equilibrates, every 4 weeks. The drawback to that is you have to go to the lab and get that test, but it's very affordable. The new ones like apixaban or Eliquis or Prodac, the ones that people like, Xarelto, no blood test. But there may be a challenge with the economics of it. These are new medicines that are sometimes more expensive. And for a while, there was no way to reverse bleeding. If bleeding occurred, you couldn't reverse it for 2 or 3 or 4 days till it just kind of ran out of its lifespan in your body. But now there are reversal agents for those. So they're all good. If you don't mind the INR, the Coumadin's probably a good way to go.
When I'm watching television, they say if you've got atrial fibrillation not due to valvular heart disease, is that important, valvular heart disease?
Great discussion in the cardiology world.
And that's what we're going to be talking about briefly when we come back. Why is valvular heart disease important in determining which blood thinner you use? Stay tuned. We're talking with Dr. George Krisle, board-certified cardiologist. We're talking about atrial fibrillation. The atrium beats too fast, and the ventricle, if it's beating irregular because of the atrium, that's atrial fibrillation. High incidence of stroke, high blood pressure, heart valve disease we mentioned, obesity, age, all are predisposing factors for this. George, tell me about the valve. Why is that important in selecting a blood thinner?
If you have mitral regurgitation, that's what makes the left atrium get so big.
What's mitral regurgitation?
The mitral valve leaks back into the left atrium and overloads, and that makes the left atrium get too big. The story there is you got to fix the mitral valve, either repair or replace, to help it address the atrial fibrillation.
So if you didn't fix the valve, then you'd be in big trouble.
The atrial fibrillation will be chronic.
So tell me, let's go back to atrial fibrillation. Tell me about the treatment of it. We've made the diagnosis, the electrocardiogram. Sometimes they find it if the person's asymptomatic, even at the primary care doctor. They come to you. What's the treatment? How do you guide people?
Say asymptomatic, do you want rate control? If they do, you control the rate plus the blood thinner.
What rate do you want?
60 to 100, as long as they're asymptomatic. Mm-hmm. However, if you say, now look, we may want to try for rhythm control here. It's more efficient. It might help you feel better. No symptoms, let's try for that. You start out with always the blood thinner if they meet certain criteria. Not everyone needs it, but most people do, especially if they're over 70. And then you offer a medicine. There's medicines like sotalol, which is gentle with few side effects. The strongest medicine is amiodarone, which is powerful, but it has side effects. You try those in sequence up to 2, 4, 6 weeks, titrate up. If you get sinus rhythm, you keep it. If you don't get it with sotalol, you can move to amiodarone. Then if the atrial fibrillation continues, you can offer electrical cardioversion. You've seen that on TV.
On television?
Yes. You come in, anesthesia puts you to sleep for 15 minutes, and we can do the little paddles 1, 2, 3 times. And that has a high success rate of achieving sinus rhythm if they're already on one of the medicines we've recommended prior to the procedure.
So it will, cardioversion will cardiovert, put the rhythm back normal. Does it stay normal frequently?
No, that's the problem. If the left atrium is too big, the atrial fibrillation will recur. So the natural history is it'll recur. But you sometimes can stay in, young people can stay in sinus rhythm for a long, long time. It's called isolated atrial fib. Have it one time, convert it, and they'll stay in sinus rhythm forever. If you're 70 plus, you're going to be making some visits back and forth.
So if you have cardioversion and you convert into a normal rhythm, does that mean you can stop all those medicines?
No, you're going to need the medicines, you're going to need the blood thinners.
Okay, so that's the important part. You've still got to continue medications, but you'll be in normal sinus rhythm. Why do you need the medicines?
To help stay in normal sinus rhythm.
Okay, now, if that works and you get a normal sinus rhythm and the medicines keep you in it, you continue that with a blood thinner.
Correct.
For how long? 6 months?
Probably forever.
Probably forever.
Now you can titrate, taper, try, if someone has side effects, you can try to taper off the medicines. The blood thinner is probably forever.
But the important thing is, just because you feel good, you have to follow the instructions of the doctor. And if the doctor says you take these medicines regular, that's what you need to do if you want to stay alive.
I think that's correct, yes, sir.
So tell me about ablation. Where does that fit into this picture?
If you try medicines, it doesn't work. Try the cardioversion once or twice, doesn't work. You do this procedure, it's a mechanical procedure, sophisticated electrophysiology, highly trained, skilled people with this rhythm in big heart centers. can do this procedure. It's a pretty long procedure. It's under anesthesia. But what you do is try to make all those little cells that are excitable, render them quiescent. And that procedure has a high rate of success, 70, 75, 80%, which is not 100%. And then sometimes the atrial fibrillation recurs and it requires a second procedure. But for individuals who are highly symptomatic and don't succeed with medicines, don't succeed with electrical cardioversion, that's a good option.
So if the ablation works, usually they don't ever have, well, you said you may have to have it a second time. Do you ever have to have it 3 or 4 or 5 times?
You can. The electrophysiology community has a great way of looking at this. Natural history, it may recur. If the left atrium's big or you're over 70, it may recur. So they'll tell you, we can get this fixed right, 70%, 80% the first time. Come back a second time, come back a third. After 3 times, that probably is enough. But they are willing to keep trying because the success rate ultimately will get to 90%. And remember, in the early days, this was the learning curve. We're getting to where people are really skilled at this now.
So they have to be sort of the super specialists. When you say ablation, now, what do you mean? What are they doing? Are they...
Well, there's different techniques, but the basic idea is there's all these excitable cells. It's called, used to be called RFA, radio frequency ablation.
Yes.
The community thinks of that as laser, but you're actually isolating the cells and trying to ablate them and destroy them so they don't make all this arrhythmia.
So how do you find the cells that are excitable? How do they know which ones to zap?
They have a mapping technique, and it illuminates everything, the size and where the action is. They're trying to isolate this area, and the technique now is very sophisticated.
Are the excitable areas more common in a certain area of the heart?
Upper left atrium where the pulmonary veins enter.
So the veins, the blood that comes from the lung to the heart, around that is the area that most common.
Yes, sir.
And if they ablate that, you have a good chance of it going away.
70% chance of success on the first go-round.
Do you guide people toward ablation, or do you guide them toward medications?
Symptoms determine that. Every patient has a great insight into what quality of life they want. If they're happy with the quality of life with medicines, that's great. Electrical cardioversion, that's great. But if you do those and don't succeed and you're short of breath, you're going to want to try this to get better quality of life. Amazing
the way you all come up with the guiding of patients that have a very serious rhythm problem. And it's serious. Its main seriousness is, number one, the rate goes so fast you're in failure, or you...
Stroke. That's the big concern with atrial fibrillation.
How common is that?
Well, a stroke instance is 75% due to hypertension, 25% of strokes are due to atrial fibrillation. But
25% of strokes.
Right, but just because you have atrial fibrillation doesn't mean you're going to have a
That's
stroke.
right. And you go to the doctor and you get on the blood thinner, so you won't have that.
It reduces the stroke rate by 68%.
That just makes me feel good. That makes me relax. That makes me feel like, you know, there's so many people. If 8% of the population has this, and as people get older and we're living older, then you can put them on treatment that allows them to have a quality of life and do what they, be able to play golf.
That sounds good.
George Krisle, you're a great teacher. Thanks for coming to the Dr. Bob Show. Any advice for people about staying healthy, preventing heart disease and atrial fibrillation?
Try to stay away from a lot of caffeine, try to stay away from a lot of alcohol, try to get 7.5 hours of sleep a night, and be sure and get an annual checkup so if you're asymptomatic, your doctor can tell you.
And all those are so important. And got to have that laughter in your life. I always enjoy talking to you, George, because you and I laugh a lot.
Yes, sir.
Thanks for coming to the Dr. Bob Show. You're a wonderful teacher.
Thank you.
Be sure you get your regular checks. Be sure you get the electrocardiogram. Be sure you follow your doctor's advice. And you're going to want to stay tuned. We're going to be talking about a new common type of headache from fluid leak from the spinal cord and gangrenous toes. What could cause that other than diabetes? A lot of information for you. I want to thank Dr. George Krisle for a wonderful discussion on atrial fibrillation. Pay attention to that one. It's a biggie. Thank you, Dr. Krisle. Now, a question from you, the viewer, that I think will be important to your health. Question number 1. Dr. Bob, I've got headaches and the doctors can't figure out what it's due to. Could you help me? Well, headaches are a huge problem. Almost everybody has had a headache at some time in their life. Usually those are not serious. But there are 4 common types of headaches in the old days. One would be a tension headache, a band headache that's on the front of the head. And we treat that by relaxing and taking Tylenol. Be sure you don't take too much Tylenol for a headache. There's a sinus infection that's usually on one side, and it's usually associated with symptoms of sinusitis, infection in the sinuses, stuffy nose, a little pressure, a little pain, a little fullness, blowing out, discolored nasal exudate. There are migraine headaches, which are vascular headaches, throbbing, pounding headaches, usually on one side, but don't have to be on one side. And then there's a banger. A banger of a headache is a headache like you've never had before. Serious, 911. That may well be from a stroke. But with imaging now, better x-rays, when I say imaging, we're now able to know that there's another type of headache much more common than people think. And that's due to fluid that leaks from the spinal column. Now, a lot of people with low back pain get injections into the spinal column. A lot of people with anesthesia with delivering babies get an epidural or get injections. People that have lower extremity surgery, sometimes they get injections into the spinal fluid. When a needle goes in to inject, sometimes in the needle site, some of that fluid may leak out. When that happens, the headaches are really quite typical. They go away when you lie down. The minute you get up, when you stand up, the blood in the ventricle falls away, and we get a severe headache that causes nausea and headache, and you just feel terrible, and you go to bed and you start feeling a little bit better. So if you have a headache that gets worse when you stand up and better when you lie down, think of central nervous system leak. Guide your doctor. He'll listen to your history, and it's a fixable thing. They can find where the leak comes from, and they can put what they call a blood patch that stops the leaking. It's like putting a patch in a tire that has a leak in it. Question number 2. Dr. Bob, does a stubbed toe cause gangrene? Well, basically, no, unless there's some underlying disease. So let's talk about a stubbed toe. Let's talk about stubbing your toe, about bumping your toe, and as you watch it and it swells, it can turn discolored. That's okay. But if you feel it and it's cold and it turns purple and you're not getting any blood supply there, then it could be that the lack of blood supply to that toe could be from peripheral arterial disease, PAD. And that's where there's hardening of the arteries of the blood that goes to the feet. When that happens, you don't get enough blood to the feet. And if you stub a toe and that toe swells and you're not getting enough blood supply to heal, then that toe could die. Now, people with diabetes, the most common cause of amputation, they have blood vessel disease in the toes. So it's another common cause of gangrene. So if you've got a blue toe and you've stubbed your toe, it could just be that you've broken some blood vessels there, or it could be that you need to see your doctor and they need to decide if they need to reestablish blood flow to your lower extremity, or if they need to get the diabetes under better control, or that we have wound care that's better. When you've got diabetes, your feet are the thing you really want to pay attention to. Your foot is your best friend. It is very slow to heal. So always take care of your feet. And if you've got headaches, think of the new headaches. It's all the time that we have for this show. Hope you've enjoyed it as much as I have. Remember, we need to be exercising. Exercising helps the heart. It develops new circulation around the heart. It decreases blood pressure. It loses sodium. It helps us feel better. We get a runner's high. We feel better. Eating properly, keeping our weight good is so, so important. We all know what good food is. In the United States, it's predominantly the portions that are causing us trouble. So we eat more food as the day goes on, and we have a big snack before we go to bed. Not the way to do it. You need to have a good breakfast. You need to have a skinny lunch. You need to have a skinny supper. And you need not to snack before you go to bed. Pay attention to the food you eat. We want to eat. We don't want to count calories, but we do want to count the amount of food that we're putting in our tummy. Remember, 7.5 hours sleep. You can't believe how important that is to your health. So be sure you go to bed on time and you get 7.5 hours sleep. And most of all, what is it we like in the Dr. Bob Show? It's laughter in your life. If you laugh a lot, you'll stay a whole lot healthier. The people around you will be happier. You'll perform better. The people around you will perform better. And you will stay healthy with laughter.